Guys, Woodruff here. I am going to start some new videos that they probably could help you throughout nursing school, but they could also be for the nurse who's out there. They're helping me to better prepare and study as I get into my new role as working in trauma with trauma patients. But these are also general good information for anyone who's taking care of a patient, especially in emergency settings and things like that. But hopefully something in here would help you one way or another. If not, it's helping me for now. So sometimes we got to be a little selfish. I learned through teaching. So hopefully you learned something along the way too. So we're talking about airway today. So airway is a big topic. And a lot of times students and people that are learning about airway can kind of mix up airway with oxygenation. Now, they have a very close connection because if my airway is not patent, I am not going to be oxygenating. But a lot of times students kind of equate someone's oxygenation with their airway patency, and they can be two separate things, even though they intertwine in many ways. They, when we're looking specifically at airway problems, think of airway problems as the airway is a hollow tube. I think of it like a garden hose. And in order for water to flow through a garden hose, there can't be any kinks. There can't be any gunk in the hose that's going to cause it to have a poor flow. It has to be open and things like that. So that's what, when we talk about airway patency, or when we talk about airway being our top priority, really what we're talking about is that if I don't have a open tube, or if there's stuff in the tube, or if the tube is swollen, I'm not going to be able to get oxygen in. And so it's all about the openness or ability for oxygen to flow in my airway when we're talking about airway patency. So then we have to ask ourselves, well, what could cause a problem where I wouldn't be having good airway patency, or I'd be having an issue with oxygenation when it comes to an airway issue? And so one of the probably most common things that can happen for airway patency is going to be swelling. This can be, you can think like anaphylaxis, like closure of the airway because of that, allergic response. It could also be swelling as a result of, some sort of trauma or injury. There is also things like angioedema and responses like that as well. There also could be trauma or damage to the airway itself. And anytime there's damage, inflammation ensues, which causes swelling. So if there's any sort of trauma, accident, injury in or around the airway, so that could be things from the mouth all the way down into the throat, any sort of trauma to those areas or damage to those areas can lead to swelling, which can lead to issues. And then another big one that's really important to note is obstruction. So this would be, this is why it's really important to look in people's mouths, especially you get a new patient, look in their mouth. It's important to, one, look at their teeth, see what they got going on, but look at what's in their mouth. See if there's blood secretions. Can you see all the way back to their throat, or is there anything blocking you there? And so the other possible obstruction, of course, could be tissue. Like if you have trauma or damage, some tissue could be pushing on or putting pressure on the airway and getting in the way. So these are a few things. The other thing that can lead to airway patency issues is if someone has a head injury, they can have a decreased level of consciousness, which affects their respiratory drive. It's not necessarily an actual problem with the airway itself, but it causes them to not to be able to what we call protect their airway. In other words, they can't manage their secretions. Like if I had a head injury and I'm not using my respiratory muscles or my respiratory system the way I'm supposed to because my brain isn't sending signals, then I'm also not going to be able to wake up enough to cough if I get secretions, things like that. So there is that as well. But some of the big ones, especially we look at in trauma, are going to be the localized swelling or trauma to the actual structures of the airway, things getting in the airway like gunk, like blood and secretions, or tissues putting pressure and blocking. So priority assessments are going to be, and this kind of, if you think of this in the eyes of like a primary survey for like a primary trauma survey, it's going to be the A for airway. But, students ask me all the time about like what comes first, C-spine mobilization or airway. And in reality now, current guidelines say to do both at the same time. So like you are watching and maintaining the airway while restricting the C-spine. So you're doing them at the same time. So they're not like one before the other. One doesn't take precedence. So, the priority assessments, of course, is that like knowing the story or history about why they came in. And if you have a reason, if there's trauma that's suspected or a potential injury, it's always better to assume they have a C-spine injury and, protect that C-spine. And there's varying research and things showing like the pros and cons of, putting everyone in a C-collar or the immobilization. I'm not going to go too deep into that. There's definitely varied, literature, and there's different, what do you call them? Like metrics and things that we look at, or when I say metrics, I mean like there's different scales, scores, or I don't want to say policies, but there's different things we can use, like there's the Nexus rules or the Canadian spinal rules and things like that can tell us a lot of times or guide us into what's the best thing to do for that patient depending on their injury. But needless to say, that's deep, deep, deep stuff. If you're getting into the trauma world, you'll learn definitely something more about it. But the big point here is we want to assume a spinal injury if we're unsure. And sometimes it may require us to put them in a collar or rigid stabilization, or other times it might be just, if the patient's able to, telling them not to, be getting loosey-goosey with their neck and try to maintain that, not be doing turns side to side and keeping it stable. So how do we actually assess for airway patency? I've asked this question many times as a professor, and I get a variety of answers. Some people say oxygen saturations, things like that. But really, like a great way, and this is the way I was actually reading a book recently, kind of, reviewing some of the stuff I didn't even think of as like probably the best way to do it, because it actually helps you assess so many things, is just ask them questions. A great way to tell if someone's airway is patent is, can they talk? Like, can they communicate with you? And so with airway patency, a great thing to do is to ask them, see if they know their name and date of birth, or what happened to them, or what's going on around them. And that tells you a lot. One, can they talk? If they can't talk, that's an airway patency issue. I'm talking about if they always had the ability to talk and now they can't talk. The people have outside things or other things going on, that's one thing. But if they're not able to communicate, that usually shows that they might not have a patent airway. And then it also shows their work of breathing. If you ask them a question and they're like huffing and puffing, like my name, it's showing you they have a breathing issue maybe too, and possibly an oxygenation issue. And then it also tells you about disability, and tells you their mental status. Like, do they know what's going on? So you can do a lot of assessments just from that one question, that one small set of questions. So just start with least invasive first. A lot of people might say, look in the mouth, and you absolutely do need to do that. You need to look in and around the structures of the airway, but start, least invasive first, and start with just asking some questions. Then you're going to, of course, want to look inside and see what's going on. But some warning signs you're going to look for is the inability to vocalize, any presence of a foreign body. So when you look inside, you're going to be looking for any signs of like swelling, any signs of an actual object, displaced bones or other organs, depending on like the injury. Like I've had patients that had gunshot wounds where they did under their jaw, and so their teeth actually became the foreign object lodged in the back of their throat. So things like that, you never know what's going to be in there. Also keep in mind, people that are elderly patients, they might have dentures or partials, so sometimes those can get messed up in a trauma, things like that. So look for anything that could be blocking the airway. And then that's going to also include any blood or secretions, like how clear is their airway, and like if there's a whole bunch of stuff, are they managing it? Like if there's stuff in their throat, are they coughing, or do they have a gag reflex? Like how is that going? It's going to tell you a lot if they're managing their secretions well, whether they can maintain a patent airway or have a patent airway. And then also looking for facial jaw or airway fractures, like any sort of well, I should say injuries, not necessarily, there's not necessarily airway fractures, but facial and jaw fractures and any sort of airway damage or direct trauma. You want to kind of look at the structures and see if there's anything obviously abnormal. So those are some of your priority assessments. Then actions. If there is an airway patency issue, you're going to either, use airway opening devices or techniques. So there's what's known as the jaw thrust chin lift. So the chin lift is used for most patients and preferred, but then the jaw thrust is a great option for patients that have C-spine issues. We're worried about them having paralysis. The jaw thrust is a great option so that we can maintain that C-spine. We can do things like clearing their airway and suctioning, inserting a temporary airway. And with that, they may need some oxygen, supplemental oxygen given, just depending. I'll talk about temporary airways on the next page. And if there's a serious airway patency issue, we want to prepare or get the tools and things that we need together to prepare for insertion of a definitive airway. And temporary airways are like the pharyngeal and the oropharyngeal airways, whereas the definitive is going to be intubation, or if it's an emergency, we do what's called criking them, where they do the incision and stick a tube directly into the airway in emergencies. And we do that for patients that maybe have stuff going on here where we're not going to be able to get a tube down. And so sometimes we end up having to do that in emergencies until they can place a more permanent like tracheostomy if that's needed. So there's obviously devices, and then, we're trying to open things up, and then if supplemental oxygen obviously is needed, we will apply that. So airway supplies. So there's two things up here at the top. This is a nasopharyngeal airway, and this is an oropharyngeal airway. And you can see here, if you ever, in real life, when you're practicing, or if it's possible, I guess that this could be tested over in a critical care setting or in a critical care class, that where do you measure? So for an oropharyngeal airway, you measure from their lips to their angle of the mandible or their jaw here. And then for a nasopharyngeal, you measure from their nose to the tip of their earlobe. And so you'd always want to kind of keep that in mind. These are used for patients that maybe are a little bit sleepy, maybe like overdoses, people after surgery, things like that. And sometimes we just do it just to keep a little bit more openness, ability to protect that airway and get things flowing. And then we can take them out as soon as the patient's awake. So this is for people that maybe don't need to be intubated, but aren't 100% where they need to be, but probably are going to be there soon. Okay. And then, let's see, let's try again. Oh, there we go. So signs of improvement or worsening, of course, we want them to have better vocal quality or ability to talk, improved mentation or level of consciousness. And I'm saying that with the thought too, though, is that for some patients, they might be getting better, but they're going to be sedated. So maybe they're getting better because we intubated them, but we're going to put them on sedation. So just because they're not waking up doesn't necessarily mean they're not getting better. It just depends on the situation. But if for someone who was having an airway issue and we fixed it and their mentation is getting worse and they're not sedated, you definitely want to consider there could be a problem there. Of course, improved oxygenation, less swelling, and then visually seeing a clear airway is always a positive thing, or they're managing their secretions. Of course, the opposite is the worst. If their vocal like these are the things that you would tell yourself, ding, 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 like I need to do something, this isn't good. Their vocal quality is worse if they're starting to have a decreased level of consciousness. If they're having worsening of oxygenation status or any swelling or signs of worsening obstruction, these are all signs that you might need to do an intervention. We always kind of trend and watch for which direction things are going, because keep in mind, some people, their initial injury, they might not have any swelling, but then as time goes on, as the inflammatory process ramps up, they can start to have some severe swelling. So we always want to kind of keep an eye on things and see which direction it's going in, and then take those necessary interventions. So this is the majority of what I think I can say about airway. There's, I'm sure, lots more to come. So as I have time and ability to do it and make it, but hope this was helpful to you, and I will see you next time. Have a great day.